Dr. Lewinsky for what we discussed, and then I just sort of put an outline together to sort of like move us forward. So um, thank you so much for being here, Dr. Lewinsky. I'm Stacy Wentworth. I'm a radiation oncologist at Duke University School of Medicine, and I am pleased to be joined with Dr. Bernie Lewinsky, who is joining us from California. Would you like to sort of introduce yourself and then talk a little bit about how you got interested in medicine, where you grew up, that sort of thing?
Okay, thank you. It's a pleasure to be here. Uh, have a long history. I'm now 82, so there's a lot of history there. I was born in El Salvador, uh, and I grew up there until I was 14. I came to this country because we ran out of American schools that we were going to. It stopped at the eighth grade. So we moved to San Francisco, and in San Francisco, you always go to Berkeley. So I went to Berkeley for college. Uh, when I came was the era where Sputnik came out, and President Eisenhower came and spoke and said, "We need engineers." So I was going to go into engineering. I was interested in electronics. I built radios and all, ham and all of that, and went to apply for the entrance exam at Berkeley, and I flunked it royally. So I said, I don't think I'm supposed to be an engineer. So I said to my mother, I don't know what to do. And she said, well, you're good with old people. Why don't you become a doctor? And I said, okay. And that was it. I applied to Berkeley, got accepted, went through pre-med and the whole thing. I didn't get into med school the first time around. It was wrong place application. I applied to Harvard, Yale, Stanford, all of the elites, and I didn't get in. So I went and got my master's degree in biology at the University of Oregon for a year, and then I got accepted to what then was the California College of Medicine. And there's a little history there. Uh, it used to be the California College of Osteopathy, and then it became the California College of Medicine, which made osteopaths legal, so to speak. And then, as we were in medical school, it became the first medical school for UC Irvine. So, for my third and fourth year, we were transferred to Irvine. There was no campus, there was nothing there. And they just shuffled us from one hospital to the other. And one of the lectures that they gave us in the first semester of medical school, for some odd reason, was a radiation oncology class. And Dr. Walter Gunn came once a week to give us a talk on radiation therapy and how to treat cancer with x-rays. And he'd bring patients with tonsil cancers and Hodgkins and showed us how they were improving with the treatment. And I thought that was
Oh,
really fascinating. And as a matter of fact, the class of 70 that we had at that time, 7 of us became radiation oncologists just because of that class.
that
And
speaks to early exposure. Yeah.
yeah, yeah. And Dr. Gunn was trained by Dr. Del Regato. So Dr. Del Regato was the big father of American radiotherapy. And a lot of uh, the people, especially the people I trained with, were trained by Dr. Del Regato. Jerry Vaith was my mentor. Started the Cerrone Tumor Institute in San Francisco, which became UCSF, part of UCSF. Ted Phillips was from UCSF, and he was trained by Del Regato. So there was a little competition between Vaith and Phillips as to who was doing a better job. Uh, and they followed Dr. Franz Buschke, who was exiled from Germany. He was a German radiation oncologist, and he ran the department very early. And he had some fabulous stories and taught amazing classes of oncology back then. Um, and then, Dr. Henry Kaplan was part of the San Francisco contingency until they moved to Stanford. So all of those people were part of the people that I was exposed to. And so after my medical school, I was offered a, a class in radiotherapy. I was offered a position at Cerrone, and it was just fascinating. It was around, I started, I was class of 70, but in 68, I did a summer, spent some time with Vaith and the group, and they installed the first betatron at Mount Zion at that time. And
Wow.
I lived near Mount Zion in Pacific Heights. And when they turned that beast on, the whole block area of San Francisco dimmed the lights. It was
Wow.
dramatic. Uh,
Wow.
and
For our general viewer, for our general listeners, can you explain what a betatron was and why that was so cool?
a Betatron was just the largest machine that was available at the time. I think it was 10 MeV. And we really didn't know how to use it. And it was all by trial and error and seeing results. We were treating APPA, AP one day, PA the next day. And and after a few people, had bowel damages, they said, we got to do both the same day. And then eventually it became four fields. And that's when all of the hip fractures started because of the ablation of the vessels of the hips. And so it was very rudimentary. We also had an AECL, Atomic Energy of Canada, experimental linear accelerator was part of the machines there, along with a cobalt machine. And we also had orthovoltage. And I brought a relic of the orthovoltage machine that I kept because somehow it ended up in my lap that I have a Del Regato cervical applicator kit that I brought out of my storage this morning to here it is.
Oh my gosh.
This
Now
is
that doesn't have radium needles in it, does
no,
it?
no, I'll show you what it's in here.
Wow, that is
This
incredible. What a piece of history.
this is supposed to go to Astro, but I don't know how to get it there. Uh,
Yeah.
but inside we had an orthovoltage machine, and this this part attached to the machine, and then this is a cervix
Oh, hold it up just a little bit
obturator.
more. Yeah.
This attached to the machine like that, and then
Uh-huh.
you applied the uh, obvious. Oops,
Oh, that's okay.
the zoomed.
Wow, that's in
Can you
oh,
see?
yeah.
Oh, very good.
Yeah.
So this you applied to the patient. This was to boost the cervix. So this
Wow.
would go right on the cervix with this obturator. Once that was applied, you attached this to the machine and you gave a boost to the cervix
Wow.
with this applicator. And, that's what we used.
And
So
this was what era?
uh,
1970 to
70,
early
71,
1970s?
70s. But obviously the applicator is older than that.
Right.
So, then I, after my first year of residency, uh, Dr. Vaith, Dr. Green, Gerald Green trained with Philip Rubin in Rochester, New York, and, and Sim Cantrell was one of the original radiotherapists from the Seattle Institute. His son was in our radiotherapy department. Everybody went to London to the Royal Marsden as part of the rotation. So after the first year, Sir David Smithers called Jerry Vaith and said, "Look, I just lost one of my registrars. He had a heart attack while he was doing a case. Uh, would anybody want to come and spend some time in London?" And I had just been married, so I said, "Why not?" So I went to London for a year. So the year of 1972, I spent in London, and it was unbelievable time. I spent time with Sir David Smithers on Hodgkin's, uh, H.J.G. Bloom, Dr. Bloom of the Bloom-Richardson classification, 3 months with him, brains, breast, and GU. Dr. Letterman was the head and neck radiotherapist, Manuel Letterman. He worked with the surgeons at Memorial. So all of the patients with vocal cord or head and neck cancer from New York would go to London for treatment. And then he would come to New York with a gooseneck lamp, a mirror, and another relic antique, a Bunsen burner. And I took a course in astro on head and neck, and they said, "You've never seen a Bunsen burner, they're antique." Well, this is the Bunsen burner. And there was this uh, thing was sticking out, and you lit the fire and you warmed up your mirror. And all you needed was a light source. So he would come with his own lamp, his head thing, and examine patients in the hotel. And he kept track of everything. His theory was you have to draw what you see. And so he learned and he taught me to draw everything I would see in the mirror. So you learn to draw everything upside down. And when the TNM system came, he had all of the pictures. So he was able to classify his cases by the TNM and ended up writing all his papers based on TNM. And his vocal cord paper is a classic British radiology journal, 2,500 of his personal vocal cord cancer case. I mean,
Unbelievable.
so I spent 3 months with him, and it was an unbelievable year.
What difference did you notice from how the Americans were treating cancer versus how they were treating cancer at Royal Marsden?
At the time, the not the word, but the thought was that the Europeans were further ahead than we were. And so they were treating much more protocol type. Everything with Dr. Letterman, for instance, was 250, 250 rads 5 times a week for 25 treatments, everything. And so vocal cord cancers, everything was done by visualization and by anatomy. And a vocal cord cancer was so easy to set up. He said, it's so simple. And we'd see a patient, he would take a caliper. He'd open up the caliper to 8 centimeters and he'd put it here. And he'd take a pen and he'd point a point here and a point there. And he had a box with little plastic squares, 5 by 5 and 4 by 5. And he would decide, he'd put the center of the plastic square on the dot, he'd draw, and he'd say, okay, go get treated. And the therapist knew it was 250 times 25, and they wouldn't call, they would just treat.
Start treating. Wow, incredible.
They seen, they started. And
That's incredible. Because now we would go through a CT sim, they would have a CAT scan and possibly a PET scan if it looked more advanced on it on exam, but that was a different era.
and he was so he would see 750 new head and neck cancers a year
Wow.
himself. So
Wow.
you can imagine what I got in 3 months with him.
Sure.
And
Yeah.
enormous. And he would say, Lewinsky, do you want to see how you treat one vocal cord? And I said, yeah. And he says, just turn the head and put the beam right on the larynx, and you'll just hit one side. And I said, how do you know you're doing it? Well, we'll follow it. And lo and behold, that one vocal cord got red, and that's
Cool.
how you followed it. Um, so
So you come back from Royal Marsden and finish up, you return to California and
I
start
went back
practicing
to
in California.
California, finished up, um, and I spent a month or 2 months doing research at the Lawrence Berkeley lab. It was, but I had come back from the Marsden with a lot of experience, and they said, you need to do some research. So I went to the Lawrence Berkeley lab and worked with John Leith and Cornelius Tobias. I met J.E. Lawrence. I met John Lyman, who was doing pituitaries. And we were trying to figure out the dose of high energy particles, helium and carbon, to paralyze rats. So we did a lot of irradiation of the rat's spinal cord. And John kept saying, we'll do single doses. And I said, come on, John, we don't do that in therapy. We treat multiple doses because there's a recovery and all of that. And so he said, well, let's do an experiment with multiple doses. So we got another 250 rats and irradiated them every day for 10 or 15 fractions and found out what the LET was for that. It was uh, it was fascinating.
You were
And
really learning the basics of radiobiology there.
yeah, yeah. And Max Boone, who was also one of the pioneers, was starting hyperthermia there. So he was treating cat squamous cell carcinomas. Uh, so, I got a lot out of being at Berkeley. We wrote several papers on that. Started to use light cast, which was an orthopedic, uh, a casting equipment. And we started doing the masks to immobilize patients because at the Marsden, they had a whole mold room where the patient would go and they would make a copy of the face, replicate it in some material, make a plastic face, plaster of Paris they used it. With light cast, you could do it in a few minutes. Now, it's the beginning of immobilizing that. Uh, Also, when I was in London, I spent a year at the Manchester, at the Holt Christie in Manchester, because that was a totally different system. And actually, Bob Kagan, who was the radiation oncologist at Kaiser San Francisco, or I should say Kaiser LA, was spending a year at the Manchester, and he brought the entire treatment protocol from the Manchester to Kaiser. And they treated 4 days a week like they did over there, and rapid fractionation. At Manchester, everything was 3 weeks, period. 3 weeks, no matter what you had, you'd get it in 3 weeks. And seminoma of the testicle, I used to sit there and I said, I don't understand. They'd go from top of the xiphoid to the sternum, from the right to the left, and they treated the whole abdomen. Why? Because they're not going to see them again. They were overwhelmed. And the patients could have metastases. So
Yeah.
anyway, I met Nisar Sayed at the Manchester. He was a surgeon there, and he was interested in radiotherapy, and he started to do all of the implants with catheters. Uh, and so then he got a position at USC, and it turned out that Dr. Sayed came to LA at about the same time that I came back from London. And so we got together. I said, Nisar, you got to teach me how to do this, because Dr. Letterman was doing everything with radium needles. And, we did an orbital implant with radium needles on a lady with a metastatic orbital metastasis from breast. And he just would take the needles and he just put them in there, make a little nick. And I said, how come? I said, the anatomy will tell you where to go. Just make a little nick, the needle will fall right in. Lo and behold, it was a perfect cone. And I said, how do you know what you did? And I said, I don't know what I did. The physicist has to tell me what I did.
Wow.
And,
I
and,
mean,
and that's how it went. It was a team.
yeah.
Yeah.
Well, you were still 25, 30 years away from CAT scan from three-dimensional
Oh,
imaging. I
we
mean, you just
had,
had x-rays basically, is it? If that
we had,
lymphangiograms,
yeah,
maybe.
we started having technetium, and we started to have technetium brain scans that were very blurred and difficult to interpret. But yeah, we started having brain scans with technetium. Um, at the Marsden, Dr. McDonald was a radiologist. He was an absolute whiz in lymphangiography. And he could do a lymphangiogram in like 30 seconds. Everybody got a lymphangiogram. And that's how we learned the anatomy for testicular cancer, for Hodgkin's disease. And he was so adept that, if we ever felt like, gee, there's a breast cancer, wonder what the lymph nodes look like. Hey, Dr. McDonald, could you do an arm lymphangiogram for us? Sure. And the next day it was done.
Oh,
Uh, it was
incredible.
unbelievable, the amount of knowledge. So Syed comes to LA, and I say, let's start teaching this to everybody at the Los Angeles Radiological Society. And he started giving lectures on that. And we formed, Dr. Syed, my partner, Dr. Fingerhut, Dr. Frey, and I formed the Endocurietherapy Society. Okay?
I don't know that one.
Well, you will in a second. We had our first meeting 1978 in Maui, and Dr. Messing, Vanderwerf Messing from Rotterdam came and taught us how to implant bladders and pull out the needles. Well, the Endocurietherapy Society grew and is now known as the American Brachytherapy Society. That's
Oh
how it
my
began.
gosh.
The
Oh,
ABS
wow.
began from Syed and us starting it. Um,
You also had an interesting, Jerry Vaith also had meetings that were happening in California as well,
yeah,
right?
yeah. Jerry Vaith started. Um, he started almost before Astro. He had the frontiers of radiation therapy and oncology, and he published every year. We had a meeting, and everybody came. It was a wild time. And it was always on absolutely the state of the art. This one in 72 was the interrelationship of the immune response and cancer. Another one was the relationship between surgery and radiotherapy. Breast cancer, nothing about preservation. It was all about, can you do less? Electron beam, hyperbaric oxygen, all of those things were at meetings at the foundation. And then Astro began having their meetings. I went to my first meeting at during the first year. There were 300 people there, and we got divided into groups of 10. So there were 10 groups and 10 professors, and we sat around the pool. Each group of 10 was on a different part of the pool. And then after, and we would sit with Henry Kaplan, and he would talk to us how Hodgkin's spread. Then Perez would talk about GYN and prostate. All of the biggies of the day were there. And then after the hour, there was a bell. Professors switched, groups switched, and another group of lectures came along. You know,
That's incredible. Where was that? In
at the
California?
Camelback Inn in Scottsdale. Uh,
Wow.
and, that was a lot of fun. So what else?
When you talked a little bit about we're still in the mid 70s here. Can you talk a little bit about the introduction of chemotherapy in the treatment of breast cancer, for example, and how that sort of changed the relationship between surgeons and radiation oncologists? And I know Dr. Delgado was involved in this advocacy for radiation, and then how medical oncology began to sort of grow, and then surgery and radiation were left sort of on the side fighting for local control.
Yeah, I was, after my residency, I went into the Army, and I was chief of radiotherapy at Letterman Army Hospital in San Francisco. Um, and I was there when, Betty Ford was the first woman to receive adjuvant chemotherapy after surgery. And then she was friends with Happy Rockefeller, Governor Rockefeller's wife, and so she was number two. And I remember the medical oncologist coming in and saying, the days of radiotherapy are over. You're not going to need radiotherapy. And you might as well find another career. And we said, you can't control the primary. You don't control the primary, you're not going to control the disease. And so we always had fights about it. And actually, I still have a list of all the chest wall recurrences that I had to show them off and say, see, look at all these recurrences. They wouldn't have recurred if we had given radiotherapy, because that's the purpose of radiotherapy, is to control the local area, not the whole disease. And we argued intensely. And, we called it the poison, but, they called radiation the burn.
Right. And that was the beginning of systemic control versus local control. But because before, all we could do was local control, for example, in rectal cancer with an APR, or in breast cancer with a radical mastectomy, and then some radiation afterwards. And then I guess what you're saying is it shifted away. So they shifted away for years to not doing adjuvant radiation as standard, even after radical mastectomy. And then, of course, now we're back to that.
This was also an interesting side thing that I never anticipated. I went to the Marsden and I was doing 3 months with Dr. Rigby Jones, who was the breast radiotherapist there. And I said to her, they're starting to give 5FU for adjuvant radio treatment for breast cancer. She says, well, if you want, go ahead and give it. And I said, how do you, I don't, what do you do? So we'll just take the 5-FU capsule and have him drink it. And so I said, okay. And so I gave 5-FU, just, drink this for now. And then, and prednisone, her favorite for adjuvant was prednisone. Prednisone is marvelous for controlling small disease. And so we picked up a lot of little things that were definitely not proven, definitely not controlled, but you learned. I
Yeah,
remember,
well, we didn't have clinical trials at that point. I mean, that was the
right,
NSABP and the
right,
CLGB were starting to be formed, and there were no
across the
clinical trials
street,
yet. Yeah.
across the street from the Royal Marsden was the Brompton Hospital, which was the lung cancer hospital. So one day at lunch, the medical oncologist came and they said, I think we found something amazing. And it says, we gave MOP to a patient with oat cell cancer, and it disappeared. And they said, I think oat cell cancer is systemic from day one. We need to give MOP to the lung cancer patients. And that's how the oat cell, small cell treatments began, just serendipity. But there they could get
Incredible.
away with it. Here, because of all the legal things, we couldn't.
How were patients, you mentioned a little bit, like how were patients tolerating treatment? So when you did do breast radi or you did do post mastectomy radiation, or you did treat these Hodgkin's patients with the betatron or with cobalt, I mean, were they hospitalized, or how were they, like, did you still see them once a week, once a day? Like, how did you manage their side effects and how did you manage them?
Well, as residents, we had to see every patient on the table before they could treat, just so that we would learn whether the fields were properly placed, blah, blah. Uh, but the patients came, we saw them once a week for follow-up. It was the routine um, all the time. And not many were hospitalized, not many were inpatients at that time. In San Francisco, Jerry began metastasizing and building centers outside of the Cerrone. So we were treating people that lived in the northern part of California, and we would fly there to do follow-ups. So that's how those patients got treated. And little by little, multiple centers were owned individually. And one of the things that happened to me, which was very unusual, is that I ended up going into a practice in Los Angeles with Dr. Fingerhut. You know the Fingerhut catalog? I don't know if you remember them. The family, the Fingerhut, he was a radiation oncologist, and he built the first freestanding radiation therapy center in LA. And so I joined him and we started building multiple facilities in order for patients not to have to be so far away from treatment. And I ended up inheriting a freestanding radiotherapy practice, which was at the time, everybody said, God, you're lucky that you ended up being able to own your own radiotherapy facility, which was amazing, except when the explosion came of new equipment, who could afford that as a private person?
Yeah.
And the freestanding radiation oncology committee society, we had to fight in order to be able to bill globally because CMS was trying to cut the costs. So that became a big problem. And eventually, now today, nobody even wants to own a radiotherapy. They don't even want to work 5 days a week if possible. You know?
You t when we talked before, you talked a little bit about the Los Angeles Tumor Institute. Can you
Yeah,
talk to me a little
Lati.
bit about that?
Yeah.
Yeah.
Yeah. So I ended up being able to um, get rid of what I owned eventually. And I got the contract at California Hospital, which was the oldest radiation oncology center in California, started in 1921. And the radiologist was Dr. Soyland. And Dr. Soyland was the founder of the American College of Radiology. And he was in downtown LA. And I pulled out, I think I pulled out, I have here the all of the orders of radium needles
Oh, wow. How
from
cool.
1948, and it was the what was the company? The Radium Chemical Company, 570 Lexington Avenue, New York. And I have all
Wow.
the receipts and all of the orders of the radium needles. At any rate, they built their own machines. They built everything there
Mhm.
on site, and they gave Madame Curie the first gold medal of the ACR. And he went to Paris with a videographer and filmed the ceremony. This was 1938, just before she died. And lo and behold, when I got to California Hospital, the foundation said to me, we've got a box full of stuff. And there's a whole bunch of tins with film in them. So I go through it, and there it says Dr. Soyland and Madame Curie. And I go, wow. I open it up and I burned my eyes with the methane from the film. And I took it to some place and I had it transferred to a DVD. So I have a DVD of that. And I told the hospital, I said, this needs to go to the ACR or Astro. I think Astro,
Absolutely. Oh,
because
that's
this
wonderful.
is going to be destroyed by somebody who doesn't know.
Yes, correct.
And,
Yeah.
and I have a film of a radical mastectomy that they did in 1930, also with this videographer. And the fascinating part was not the incision that went from head to toe and the process, but at the end of the surgery, the surgeon calls the radiologist. And the radiologist, Dr. Soyland, put 3 or 4 radium needles in the level 3 nodes. And he says in the video, which is all typewritten, not voice, that cancer can recur in the upper nodes because we can't get to them. So he treated the upper cervical nodes with radium in 1930, you know.
Unbelievable. Do you know what dose, how many rads he gave?
It was like, I think he said 3,000, 30 gray, something like that.
Sure. So he's
It was
treating a
right.
supercloud field. Amazing.
Keynes, you know about Keynes,
Yeah,
Keynes?
Jeffrey Keynes. Yeah.
Yeah.
Hmm.
He was the first one that did radium implants of the breast. And he published the paper, I think it was 1916, if I recall. And that paper never was seen again because the surgeons didn't want people to see it. because the last sentence in his paper is, with this technique, you will never have to remove the breast. It was whole breast radiotherapy with radium, right?
It
And
only took 75 years after that for,
yeah, yeah.
yeah,
So
that's,
the Lati, I ended up practicing there the rest of my last years, and I had to, as I said, I had to get rid of the ownership, and so UCLA took over, and unfortunately, they closed the department.
wow.
They they just closed it. First, they got rid of the old man, and
Yeah.
they do these things very legally.
Mhm.
And they
Yeah.
said to me, I'm 82. They said, you have to work full time or not at all. I said, oh, I get the hint.
Yeah.
So I
Yeah.
retired.
That's,
Yeah.
can you talk about your work with Dr. Silverstein? We interviewed him and with the Van Nuys Breast Center and
Uh,
working with DCIS and breast conservation. You were a partner in that.
you have another hour?
Yeah.
Uh, yeah, Mel came to us 1978. He came, we were freestanding, and he came to us and said, look, you guys, I want to start a breast center. If you support my tumor board, I will send you patients. And I said, okay. So every Wednesday he had a tumor board, and he had the group that he showed you in his talk. I was part of the group, and we discussed every case he saw, and we had huge arguments about chest wall irradiation. I mean, that's where it all began. And Dr. Gamagami came to the team. He was trained in Marseille and was an expert in breast. Excuse me. And he started finding all the DCIS cases. And
Because
Mel
he was the radiologist. He was
was
the mammographer
radiologist.
that came
Yeah,
over.
he
Yeah.
was radiologist and did nothing but breast. And he also did thermography of breast, which was common in Europe. And thermography was taken over by the GYN, by the GYN people. And they misapplied the technology to the
Mm.
point that the American College of Radiology said thermography is lunacy, get rid of it. Well, I'll tell you, under Gamagami's eyes, it was an amazing follow up method because we could pick up the regrowth of blood vessels long the hyperthermia from the blood vessels long before you could see them on the mammogram.
Interesting.
But when the community started saying they're a charlatan, don't go there, we had to stop doing it.
Right. Right.
But you know, the politics of medicine have been there from day one. Uh,
Yes.
and I invited Dr. Silverstein because our breast center was really growing. And I was at another hospital at the other end of the valley, and they were still doing mastectomies and all that. And I said, you know, Mel, would you give a talk to West Hills Hospital for me? He said, sure. So he comes, you know, the title of his talk says, Why Your Patients End Up in My Clinic.
Oh no.
The surgeon who just recently passed away said to me, Bernie, I'm never sending you another case because you got Silverstein here. And lo and behold, for a long time, he didn't.
Really?
He'd refer them out, you know.
Yeah.
So,
Yeah.
but we worked together. We met all the time. He got divorced about the same time I did. We had kids that were friends. We met every Saturday at the Country Mart, a place here in LA. had coffee, met people. And when there was no one to talk to, we talked breast. And we talked about DCIS. And he was a genius in that he had a computer from day one. And he recorded everything. So I'd say, Mel, how many right-sided DCISs in the inner quadrant did we treat last year? I'll let you know in an hour. And little by little, we put all the data together that the VNPI was an outgrowth of all the meetings that we had. And so, Barbara Faubel really did not like us at all.
Can
And
you
she,
just explain a little bit about the VNPI and what that concept was, and then sort of
yeah, it
before
was
you enter into the controversy?
well, it was the Van Nuys Prognostic Index. We were trying to figure out whether size, location, margins, and pathology could predict the outcome. And so with the computer, we were able to separate the low-grade DCIS and look at the follow-up and the recurrence rates and say, look, if you have a really low grade, and we started grading them as 1, 2, 3, 4, 5, 6. And so we say, if you have a 1, 2 small lesion, margins are clear, you don't need to have radiotherapy. And I would fight Mel and I'd say, that's wrong. They all need radiotherapy. And, and without telling me, he kept a whole bunch that he didn't do radiotherapy on. And so
Right.
data came with time. But that's how the VNPI grew. And the treatment of DCIS expanded. I wouldn't say only because of that, but that helped understand the disease because nobody knew what it was. Nobody had
Right.
an idea of what, if you look at Halstead's patients, the smallest tumors were 2 centimeters. They didn't have 2 centimeters and gazillion nodes. So they didn't know what a non-visible, non-palpable disease is.
You are right in the middle of LA and Hollywood, and it is celebrities sometimes that can influence our patients' decisions on cancer. Did you ever see that, or did you struggle with that in treating out there? I don't know if you want to speak on that a little bit.
Saw that a lot. Um, Patients would follow what some famous people would do. And I'm not going to name names, but there is one person in particular, and she recently passed. She refused to take tamoxifen. And, that was sort of not standard. And yes, she never recurred, but she had a book signing. She wrote a book and went to some um, plastic surgery clinic to get some wrinkles changed or removed. And she was found out by the media, newspaper. And they published a picture of her coming out of the plastic surgery clinic. And she said that she had radiation problems, that the radiotherapy had so damaged her breast that she needed plastic surgery to repair it. Well, Mel did the surgery, and I know who gave her the radiation, and I know who followed her, and she didn't have. But these are the things that came out of the notoriety of people. And look, we battled that with the surgeons. Um, the era of cobalt, they would come out and they tell the patients, you're going to have a charcoal breast. And they would have a picture of a patient that was treated with cobalt. And what happened with cobalt was that when the radiologists, not radiation oncologists, started using cobalt, they were used to using orthovoltage. And they were treating to what was known as erythemadosis, which was the redness of the skin that told them that they were getting close to the treatment. When cobalt came, the Dmax was under the skin. So when they treated to erythemadose, they were way overdosing patients. And that's why they had the reactions. And that's why cobalt had and still has a bad name. But these are the things that happen that had nothing to do with science.
Yeah.
And, we had a
I
hard
think they
time.
live inside, I think they live inside children's brains that remember their dad or grandfather coming home with that. And that is just so, yeah, difficult.
And radiation as a whole has suffered from that.
Yeah.
And I always ask patients, why is it that you're against it? What have you heard? And it was always Aunt Tilly of someone else who went to somewhere else who knows what disease, you know. It was
In the span of your career, you have seen, I don't know what the last machine you treated on, but you've gone from a betatron, cobalt, and radium needles and treating AP one day and PA the next to probably treating on some sort of an amazing, I don't know, TrueBeam or Elekta. And do you have more hope for cancer right now? Like you have just such this long arc of history of seeing the learning curve of oncology. And I have a much shorter learning curve, but I feel very hopeful right now that we're finally getting to like personalized cancer care. Do you feel similarly, or do you
I
feel
feel
like we still don't know a
similarly.
lot?
I feel
Yeah.
very optimistic with a caveat, and that is don't forget the past. Okay. And what I mean is what I saw being done at UCLA, and I we didn't have the fancy machines at California Hospital, so I have not done SRS, SBRT, but I obviously follow it, and I did tumor boards at UCLA, and the pinpoint treatments, you know, totally evade the oncologic principles that we grew up with. For instance, high grade prostate cancer has a lymph node. First of all, only the prostate was treated. So I go, what happened to the lymph nodes? Oh, we don't need to treat them. Oh, patient got a lymph node recurrence in the pelvis. Oh, we'll do SBRT on it. SBRT. Couple months or whatever, another lymph node pops up. PSA goes back up. Oh, we need to treat that. Well, why is that happening? It's because the lymphatics between one lymph node and the other were not treated. And so that's what I'm saying is that you can get so fancy that you may be retrogressing in the local control. That's what I'm afraid of. But, I had that argument in a long time ago at the Lawrence Berkeley lab. And John Lyman, they were trying to treat pancreas because it was and still is such a difficult disease. And they had the beam. And when you send a heavy particle, there's a little amount of X radiation at the end, at the side of the peak. And they were saying that they could direct the beam by the Bremsstrahlung was of that area. And I said, well, how do you know that the lymph node and the lymph channels don't have disease? Just by going around the perimeter of the pancreas, you're not going to get all the disease. And they went, oh, that's interesting. And that's where we are today, what I'm talking about. Same sort of thing, you
Yeah,
know.
it's very, yes, we can get so caught up on what we can do. Sometimes we lose the bigger picture of what
And
we should do.
and I remember Eli Gladstein, you know, did you know Eli?
I did not ever meet him, but I, of
Oh,
course, have
he
heard him.
was
And
one of the
yeah,
most delightful. Look, when I was in London, we had a spontaneous meeting at the Marsden. Henry Kaplan came to visit Sir David. Saul Rosenberg, the medical oncologist with Kaplan, was at the Marsden. Eli Gladstein was doing work at the Hammersmith. Michael Peckham was uh, Smithers' right man. We all just sat there and argued about whether Hodgkin's travels down or travels up.
yeah,
Spontaneous. Everybody happened to be
amazing.
in London at the same time.
What
But
an amazing experience.
Eli Gladstein was furious when IMRT started. Okay? And he'd say the integral dose of radiation that you're giving patients with this IMRT idiocy is going to cause a lot of cancers because of the peripheral added dose. And, he was adamant about that. And,
Yeah,
now it's so much more accurate, so much different, and so precise. I mean, when you start talking about blocking the nodes in the heart to stop arrhythmias, we know we're very specific. And I'm fascinated with that, but I never did it.
yeah. Well, great. Anything that we missed or anything that you wanted to
Well,
share
let me
as we
see.
finish up?
Um, no, I think I showed you oh, here is an original MIC applicator. This is the
Do you want to
original.
explain what that is to the
Oh, the
viewer or
MIC
to the listeners?
applicator. This is a gadget that Mr. Mick invented we put I-125 seeds in this little cassette. You put the cassette in here, and then you implanted needles into the tumor, mainly the prostate. And then with this gadget, this uh, probe would go into the needle like that, and then you would inject a seed while you pulled up half a centimeter and put a seed in so you would implant that.
Unbelievable.
And we did
And
implants. I tell you, I did implants of the pancreas, and it was interesting. I went to a meeting in London. They invited me to talk at the Royal Marsden on my 52 years since the Marsden, and they were talking about uh, pancreas. We need to find a way to really just boost. And I remembered I would, they'd open up the patient, go into the OR. The surgeon would separate the Douglas pouch, I think it was, and I would put my hand in the Douglas pouch with the aorta going like this on the back of my hand. And then we would take the needles and push them until we felt them come into our hand. And then you have all these needles sticking out. And with this applicator, we would then inject I-125 seeds in. And if the patient survived, we would say, well, it must have been the wrong diagnosis. Nobody survives.
nobody survived. I have to say, just before we leave, would you like to talk a little bit about your current project with your landscape photography and where you've
Oh,
sort of
yeah,
taken your creative energy
yeah,
now? Because I think that's a really important part of holistic care of patients and of ourselves.
yeah. Well, it all began in El Salvador. When I got, when I was a boy, I was just fascinated by the active volcano that we had. And I started photographing um, at age 8. And I always loved landscape. And I started putting some of my photographs in the office. And patients were fascinated while waiting or after treatments. And it became my observation that there is a healing aspect to nature photography. And putting it in the office when a patient is under tremendous stress, it not only calms the patient, but it brings back memories that they cherish. And I'll give you the one example was in London, April, May, cherry blossom time. Took a picture of cherry blossom, liked it, nothing special. Had my clinic in LA, we remodeled it, pastel colors. I said, oh, that cherry blossom might look good in there. Printed it, pasted up there. One day I saw a patient with prostate cancer, Latino guy, and he just sat there, mesmerized. And the wife said, hey, the doctor doesn't have all day. Pay attention to him. And I said, wait a minute. Let me ask him, what is it about that picture that's got you mesmerized? And he says, I remember when I was a little kid, my dad would take us cherry picking. And I sure wish my dad was here right now.
Oh, that's
That did it.
wonderful.
That was it. From there on in, I knew. And I, fortunately, when I was with Vantage Oncology, that took over part of my practice, or the technical component, we built the West Hills facility, and they let me work with the architect to uh, put art. So the theme that I had was it's an art gallery where you just happen to get radiotherapy.
I love it.
And
I love it.
and we had to build the vault outside the building. And so we had to connect it. So in the passageway between the old building and the vault, I put in these floor to ceiling waterfalls, and I put troughs with rocks in them and little fake plants and a sound of rain and water. And there was a transition that the patient had to go through to get to the vault that just took their mind off the treatment. And I have to say that I'm very honored. The California hospital, they built a new women's center, and in the center of the old hospital and the new hospital is a little courtyard, and they're naming it Dr. Lewinsky's Healing Garden.
Oh, what a
So
tremendous memory. That is fantastic. What an honor.
yeah,
Yeah,
so
part of that's a wonderful approach to just think about what the patient, to us, we're going to work every day, but that's the patient's first experience with something as
I
horrific
had,
and as life-changing as
I
cancer.
had patients that were upset that their treatment finished because the half an hour of waiting or whatever time was the time that they could sit and relax and just calm. And
Yeah.
I'm trying to write a book correlating all of that. It'll get done, I hope, before I go. But anyway, it gets done. It'll be
Well,
mainly for patients to
we can't
understand.
wait to read it. I think that there's so much wisdom there, and the patients are ultimate teachers, right? I mean, they're learning from us, and sometimes I feel like I come home during the day and I've learned more from them. So,
Yeah,
yeah.
yeah.
Well, well, thank you, Dr. Lewinsky, for your time. We really appreciate you sharing all of this with us. And of course, such a fascinating history of radiation oncology encapsulated in a single person's career. It's just absolutely mind blowing.
It
Thank you so
is
much for being with
my
us.
pleasure. Thank you.